Hi everybody, I'm Lauren Leggett, Medical Director of Education here at SWORBHP. And I'm here today to give you another one of your ACP case studies for your 2019 Mandatory CME. This year's overarching topic is pediatrics, but some of your ACP case studies go beyond that, and this is one of those. So it's a case study on overdose, but we will be touching on more than just overdose itself. So without any further ado, here we go. So you were called to a residence for an overdose in a 50-year-old female. You are met at the doorway by the patient's friend. They tell you she's overdosed on her medications after a fight with her spouse. She tells you the patient was left alone for maybe about 5 minutes while the friend used the washroom. Upon returning, all of her medication bottles were empty. The scene appears safe. It's a tidy townhouse condo with only the patient and her friend present. The patient is alert and oriented ×3 with a GCS of 15 and ambulatory on scene. There are 3 empty pill bottles filled today on scene for the following: 6 tablets, 120 milligrams of methadone, 56 tablets of 0.5 milligrams clonazepam, and 140 tablets of 25 milligrams amitriptyline, the trade name Elavil. A brief patient history gives you no previous surgeries, an allergy to morphine, which gives a rash. She's only on the 3 medications that were found empty. She last ate dinner, which was pasta, about 4 hours ago. And the event surrounding the call is that the patient had a fight with her spouse. Her friend came over to console her. When this friend went to the washroom about 30 minutes ago, all of her pills were accounted for. However, when she returned, within 5 minutes, they were all gone, and the patient admitted taking them to, in her own words, go to heaven. Although the patient has a long-standing history of depression, she has never attempted suicide, nor has required admission for mental health reasons. So your physical exam gives a patient who is pacing and tearful. She is alert and oriented with a GCS of 15. There's no apparent trauma. Her vital signs are as follows: temp 35.7, heart rate 100 and regular, blood pressure 131 on 88, respiratory rate 18, regular and full, SpO2 94%, and her pupils are 3 millimeters and reactive bilaterally. The rest of your physical exam, including head, neck, chest, abdo, back, pelvis, and extremities, is unremarkable. When you hook her up to the monitor, this is what you see. En route, the patient deteriorates quickly. She's GCS 14 within 1 minute of transport, starting to become confused. And within your 10-minute transport time, becomes GCS 3. So on arrival to hospital, her vital signs are now as follows: heart rate 120, blood pressure 104 on 69, a respiratory rate less than 4, SpO2 83% with your bag valve mask initiated, pupils 4 millimeters but sluggish, and a blood glucose of 8.2. So what's going on here? We know there's been a polypharmacy overdose. Let's go over what each of these meds can do with overdose. So methadone. It's an opioid medication that can cause decreased LOA, respiratory rate, and blood pressure. It can also cause increased QTc, causing torsades, but your tracing didn't show this. Clonazepam is a benzodiazepine and can cause decreased LOA, respiratory rate, and blood pressure. Amitriptyline is a tricyclic antidepressant and needs more than just this slide to discuss its effects, especially in overdose. So TCAs have many actions. The first is that it's a sodium channel blocker, which causes a wide complex ventricular arrhythmias. The second is that it's a potassium efflux blocker, so it causes increased QTC, which can lead to another arrhythmia, torsade. It's also an anticholinergic, so these patients are hot, but not sweaty, altered with enlarged pupils, tachycardic, and hypertensive. It's a serotonin and norepinephrine receptor inhibitor, which gives also agitation, as well as an alpha adrenergic blocker, which gives hypotension. It's also an antihistamine, so again giving sedation and vasodilation. And finally, it's a GABA inhibitor, which can cause seizure. So that's a whole lot of badness in one drug class. So how can we know how bad things are? Before we go over that, here's a diagram showing just how ugly those TCA ECGs can be with those deadly arrhythmias. So the sodium channel action stretches out the QRS, and the potassium blocker stretches out the QTC. So looking at TCA toxicity, it's rapidly absorbed, so within 1 to 2 hours from the GI tract. It reaches its peak concentration 2 to 4 hours, and its toxicity can be predicted based upon symptoms as well as increased QRS. There was a landmark study published in the New England Journal of Medicine in 1985 by Lovejoy et al. That found that the QRS duration can predict the risk of seizure if the QRS is greater than 100, and ventricular arrhythmias if the QRS is greater than 160 milliseconds. Therefore, the QRS width becomes the target for therapy. Well, what therapy? Let's go over that next. And before we do that, let's quickly look at the QRS remembered from your initial monitor. So this is what it looked like when you saw the patient and her GCS was 15. The QRS was not wide here. Well, this is what it looked like in hospital. Definitely wider. So here the QRS is about 128. And again, definitely over that mark of 100 in which we want to start treatment. But what was that treatment again? So first off, you start with standard resuscitation. If the patient is hypotensive, initiate a fluid bolus. If the patient arrests, you follow your cardiac medical directive, with one caveat. Remember that these are the special circumstance patients wherein consideration for early transport is important. But also, another treatment for this overdose is sodium bicarb. Remember that TCAs are sodium channel blockers, so to help stop the arrhythmia, we give them sodium. It's not the bicarb buffer that we give them sodium bicarb for, it's the sodium. So this will require a BHP patch. The dosing to expect and ask for is 1 to 2 milliequivalents per kilogram. Since 1 amp is 50 milliequivalents, that's 2 to 3 amps IV push. One more important thing to note is that although this overdose can cause ventricular wide arrhythmias, amiodarone is contraindicated. Although your service may carry this specifically for ventricular arrhythmias, amiodarone itself is a partial sodium channel blocker, and therefore, if given, can worsen the arrhythmia. Note, however, that lidocaine is actually the antiarrhythmic of choice in TCA overdose. So if your service carries this, it's very safe to give. Also of note, if the patient seizes, midazolam is also safe to give. So let's talk a little bit more about sodium bicarb. It's a drug that's not written into any of the directives. However, it can be used in certain situations to assist with resuscitation. Here is the AHA suggestion for the use of sodium bicarb. They note that the routine administration of sodium bicarb is not recommended in cardiac arrest, with a class 3 recommendation, level of evidence B. It, however, may be administered for treatment of some toxidromes, specifically TCA overdoses or other sodium channel blocker medications, or hyperkalemic arrest in the setting of acidosis. And this is given a class 2 level of evidence C, recommendation. So let's go over that prolonged arrest part again, because we know that this may create a bone of contention. So bicarb was removed from the AHA arrest algorithm in 2000. At this point, it was left up to the physician discretion. And in 2010, a stronger messaging was provided, and remains until today, that sodium bicarb may be considered for treatment of some toxidromes, specifically tricyclic antidepressants or other sodium channel blockers, or special resuscitation situations, such as hyperkalemic cardiac arrest. Now, we know that sometimes you see it given in hospital. Oftentimes, it's quite culturally driven and not standard practice in all centers, as the evidence is not great. The hypothetical pathophysiology is that it can correct acidosis, bringing the pH back to closer normal physiologic conditions, which may allow for other resuscitative measures, including drugs, CPR, and electricity, to work better. But this is in the setting of us being able to measure, monitor, and titrate pH, and in the setting where this adjunct can be given concurrently, while standard ACLS, what we know saves lives, is ongoing and not compromised by attention being given to sodium bicarb administration. A lot easier to do when you have all hands on deck, instead of just yourself and your partner. Note, however, that if the BHP requests sodium bicarb when contacted after the third epi or third analysis, go ahead and give it. There are certainly some regions wherein bicarb use is common, since this is their practice and an arrest under their region and care, and it's within their practice to use it. Please follow their BHP direction. So, what does the evidence show? It appears that unchecked, the buffer doesn't equal better. The majority of evidence with outcomes of ROSC, survival to discharge, and meaningful neurologic recovery show either no benefit or even harm. For example, a recent study published in Resuscitation looked at the outcome of out-of-hospital cardiac arrest in British Columbia from 2005 to 2016. Those treated with sodium bicarb versus those not treated with sodium bicarb. They found worse survival, 2.3 versus 19.8%, and worse neurologic outcome, so favorable in 1.2% of those given bicarb versus 10.6% in those not given sodium bicarb. So what can potentially cause these bad outcomes? Well, unchecked buffer can cause impaired oxygen delivery, as the alkalosis caused decreased offload of oxygen from the hemoglobin. Remember that good old hemoglobin oxygen dissociation curve? It can also produce metabolic disturbances such as hypokalemia, which alkalosis causes it to be shifted out of the blood. Hypocalcemia, remember bicarb is a chelator with calcium gluconate and cannot be given at the same time. Hypernatremia, remember it's a sodium donor. And it can actually cause paradoxical intracellular, including those myocytes and cerebral cells, acidosis. Going way back into physiology, bicarb, when added in excess, will be shifted into CO2 and water, which is then shifted all the way into this, which can cause intracellular acidosis and impair cardiac function and decrease the VF threshold. In summary, please consider a patch request for sodium bicarb for TCA overdoses, especially with symptoms or QRS greater than 100. Maybe for hyperkalemia in the setting of acidosis and arrest, but making sure that this does not compromise standard resuscitation, what we know saves lives, including other aspects of hyperkalemia medical directive, calcium gluconate, and Ventolin. And try not or withhold, we should say, a patch request for prolonged arrest or crush injury prior to extrication. So if they're not quite hyperkalemic, but you think they may become hyperkalemic after release. Again, we're not saying you should never give sodium bicarb in these situations. If the BHP requests its use, please oblige. Or if there's an extenuating circumstance where you think it might be pertinent, you certainly can request it. What we're providing you with is the evidence behind its use and the suggested patch request practices. So no doesn't equal never. So let's look back at our case. The patient was GCS 3 with SpO2 83% upon arrival at the hospital. In the emergency department, resuscitation was continued. The patient had a multi-drug overdose, and in order to optimize the TCA resuscitation, first naloxone was administered. A total of 1.2 milligrams was titrated, and the patient roused to a GCS of 10, then able to control her own airway with an SpO2 of 100%. Following this, sodium bicarb was given, 3 amps every 5 minutes times 2, and the QRS narrowed. Note that we actually maxed out the treatment of sodium bicarb therapy based on our labs. The pH was greater than 7.55, and therefore the patient also received 3% or hyperosmolar sodium chloride. So this is beyond the detail needed for this case presentation, but just out of interest. Then, following resuscitation, the patient was intubated via RSI for expected course and to facilitate activated charcoal removal of the drug via the oral gastric tube. The patient was then initiated on pressors within 45 minutes of arrival, as the overdose really started to kick in despite the decontamination with the charcoal. And the patient was on 2 different pressors before leaving the emergency department for the ICU. However, the patient did well and was discharged from the ICU on day 2 of admission and discharged from hospital on day 5 of admission following psychiatric clearance, and her TCA medication was stopped. So in summary, tricyclic antidepressants or TCAs can be extremely lethal in overdose. Treatment includes standard resuscitation. Consider early transport and arrest. Do not give amiodarone. Consider a BHP patch for sodium bicarb, 1 to 2 milliequivalents per kilogram IV push, and your goal is to titrate to a QRS of less than 100. When it comes to sodium bicarb, the suggested patch request practices are yes for TCA overdoses, maybe for hyperkalemic arrest in the setting of profound acidosis, no for prolonged arrest, and no for crushed injury prior to extrication or without signs of hyperkalemia. But remember, no doesn't equal never. We're not saying you should never give it. We're providing evidence-based suggested patch request practices. If the BHP requests sodium bicarb, please oblige. If there are extenuating circumstances, don't feel you can't never request it. So here, we're not saying no equals never. Here are some of the resources, and thanks again.